Good morning. My name is Mehdi Razavi, and I would like to take this opportunity to discuss some of the clinical research and innovation undergoing here in the field of cardiac electrophysiology at Texas Heart Institute. We're going to discuss two of our projects that we found most interesting. The first one is addressing the underlying substrate for malignant ventricular arrhythmias. As we know, ventricular arrhythmias are the most common cause of sudden death in this country. And the causes for these ventricular arrhythmias are multiple, but what they share as an underlying pathophysiology is the presence of delayed conduction, very often created by functional or structural scar tissue. And the problem that the scar tissue presents is the fact that when you have areas of scar, you can have tissues that create reentrant circuits, microscopic circuits in these regions. These areas are not approachable by pacing using current pacing technology. And the hydrogels performance is going to be dependent on the ability to access the intravascular space using these hydrogels, injecting the hydrogels into the epicardial venous system, which then percolates in and around these regions of scar and directly captures the scar. By direct capture of the scar, you are preventing the conduction delays that lead to the reentrant arrhythmias that are the focus of sudden cardiac death. By way of comparison, trying to actually use point pacing to perform this is nearly impossible. It requires multiple locations, and right now our only and best wireless form of point pacing still is about the size of the average phalanx on the tip of your pinky finger. These pacing technologies require large bore sheaths, and placement of multiple electrodes targeted in the regions of scar is quite challenging with these larger wireless pacing systems. So having said that, what our current technology performs is it percolates into these areas of delayed conduction without needing to use a specific metal-based large pacing electrode. The pacing energy is delivered through the hydrogels that are injected into the vascular space. In order to achieve pacing via the hydrogels, we have to inject the precursors and allow these to mix into at the base of the anterior interventricular vein. Once the precursors have mixed and been cured, then connection with a pacing lead enables capture of along the entire course of the hydrogels. We first document that the hydrogels are indeed conductive and assess the conductive properties of the hydrogels as they are sitting and being cured in the anterior interventricular veins. We want to make sure not only that they're conductive, but that they're biostable, cytostable, hemocompatible, and mechanically robust. In vivo injections are demonstrated here. You can appreciate on fluoroscopy the filling of the anterior interventricular vein as the hydrogels are injected. We can see here that over time the conductive properties of the hydrogels and the hydrogel homogeneity remains intact. We also see here that pacing via the hydrogels creates electrocardiogram morphologies that are much more similar and nearly identical to native conduction electrocardiograms, as opposed to point pacing with hydrogel or with metal electrodes. This reinforces the fact that we are capturing the mid-myocardial tissue directly. Furthermore, in studies that we performed using three-dimensional electroanatomic mapping and propagation, we showed that areas of scar are actually also activated earlier when using hydrogels in the anterior interventricular vein. Here we can compare point pacing and pacing from the hydrogel at the endocardial and epicardial aspect. What we appreciate is that on the endocardial aspect, on the middle panel, bottom row, middle column, we can see a wider area of red, which is the earlier activation. The patterns are such that earliest activations for all these slides starts with the red color, and it gradually progresses on with the blue and lavender colors being the latest. Here we can see how the area of scar, if you focus on the bottom row versus the top two rows, you can see that the regions of red are much more extensive, especially on the endocardial aspect. The blue dots represent area of scar and injection of the hydrogels. And as you can see, with point pacing, if you look at the top two rows and you compare it to the bottom two rows, the amount of red, if you will, which identifies areas of early activation, is much greater in spite of the presence of scar with the hydrogels. Here we can appreciate activation of the hydrogels of the myocardium with and without hydrogels. Here you can see right ventricle, left ventricle, and the activation is, as you can appreciate, is more delayed. The colors are not as red, if you will, as they are in the subsequent video. Here, this is the AIV, the anterior interventricular pacing, and you can appreciate how much more red colors early activation you have, and not only that, how simultaneous the left and right ventricle are in activation. I will play these two videos one more time, and I want to focus your attention on the extent of red coloration or the absence thereof with point pacing versus hydrogel pacing. So let's do this again. I'm going to start with the point pacing. And first thing you see, you notice how the colors are much more red on the right side with hydrogel pacing than with point pacing on the left. We are rotating this around, and now you will also see the propagation. There you see the propagation. You can appreciate how it starts on one side and then it goes to the other side. This is the fact that this demonstrates the fact that we are not in the middle of the heart capturing the mid-myocardial tissue directly. This, as opposed to what we see with the hydrogel AIV pacing, where the regions of red are far more extensive, and you see the simultaneous activation of both bottom chambers as follows. Okay. Having said that and demonstrated the efficacy of the hydrogel pacing, we want to see how these would function in a chronic porcine model. And indeed, we have found that the hydrogels do not cause any significant level of myocardial necrosis. We did serial echocardiographic parameters and histology testing, and we found that no evidence of myocardial infarction or myocardial necrosis with injection of the hydrogels after a 1-month chronic observation period. So our next steps is we will continue our current research and development. We want to test the system not only with pacing technologies, but we believe that ablation technologies and neural applications will be very, very important features of this technology. I would also now like to discuss another collaboration we are doing with Dr. Behnam Ajang, Department of Electrical Engineering at Rice University. I forgot to mention the original work I just discussed was with Dr. Elizabeth Cosgrove Hernandez at the University of Texas. This work with Dr. Behnam Ajang is looking at machine learning in the field of electrophysiology. We believe that machine learning has significant implications towards a more smooth and streamlined practice of electrophysiology. Two simple examples are as follows. We have done work showing that in a retrospective diagnostic electrophysiology study of 14 patients, concurrent EGM and 12-lead intracardiac electrogram and 12-lead ECG signals were compared. And we were able to, using one electrocardiogram channel that was obtained from a diagnostic catheter in the coronary sinus, create 12-lead ECG signals for 14 patients with an average correlation of 0.9. That is quite phenomenal to be able to create a 12-lead ECG based on just having a scattered number of intracardiac electrograms. The other study that we have done and have published shows that we have been able to minimize the number of mapping sites required for successful ablations, thus decreasing the duration of these procedures significantly and increasing the safety. This is our team, and once again, I would like to thank everyone for listening to this broadcast. Thank you.